Today on the Transplant Helper, I'm going to talk about two very special considerations you need to really think about right now if you happen to be facing a double organ transplant. Stay tuned.
Hit the subscribe button and the bell notification to become part of the Transplant Helper community.
Folks, welcome back to the Transplant Helper again today. My name is Jim Merle, and perhaps you're like I am, you already know that facing an organ transplant of any kind is going to be especially difficult and especially trying in your life. Now, with that being said, I also know that there is no doubt in my mind that anyone who is facing a double or perhaps sometimes even a triple organ transplant, they're facing 2 to 3 times the trial that I've ever faced in my life. However, I was asked a question just the other day by a great friend of the program who happens to be facing right now a double organ transplant consisting of a heart and a liver. Now, for whatever reason, oftentimes the heart and the liver transplants do kind of come up together. I think that is because when you're in severe heart failure, it immediately damages things like your liver, your kidneys and such. That's just the way it is. That's what oftentimes happens. So anytime you're facing a double failure, you're kind of getting a double dose of things, and it can be very, very difficult. Facing one failure standing alone is hard enough. Facing two, obviously, double trouble. That's about all you can call it. So me having gone through heart failure for a period of time of about 6.5 years, really my whole life, but at least the last 6.5 years prior to transplant, I know exactly what it can be like. Those days that I was really sleeping 16, 18 hours a day, hardly able to get up and do anything at all around the house, not really able to move about, eating a meal, whether it be breakfast, lunch, dinner, supper, whatever you want to call that, and just collapsing after that, falling out asleep after a shower, even brushing my teeth became difficult. I know how that is, and I can imagine if you're dealing with something like this person, a heart, potential liver transplant, that double failure is doubly hard. That's just the way that it is. So first of all, that's what you need to consider, and that is that facing a double failure can seem to be twice as hard. But with that being said, there's another thing to consider in this, and that is you must also consider the find, okay? The matching of these organs is going to be extra difficult. Once you get past that failure, maybe you're listed officially for transplant, you're on the list, and say for the heart and the liver list, the find itself is going to be more difficult, because what they like to do in most cases like this is, if at all possible, they're going to try to bring you those two organs at the same time during pretty much the same surgery, and particularly they're going to want to bring that over from the same donor. That's really for great reason, and that is that way they're only battling one donor type, blood type, tissue type, whatever type. They're only battling one of those types as far as you having rejection, okay? And so if they can get both organs from one donor, then that's going to be a plus. And in the case of the heart, that 100% always has to be a deceased donor, and that's a sad thing. That's an obvious thing the way it is, and more times than not, those deceased donors come as a result of some type of head injury or trauma. Now, whether it is actual injury like an accident, or whether it is something like a severe stroke or an aneurysm, whatever, a lot of times those hearts come from that deceased donor, and that donor being deceased because of head trauma. Now, when you have that occurring, particularly on the accident side, say a car accident or something related like that, there's always a potential that although the heart could be viable and ready to go, the liver, the kidneys, whatever, there can be other damage done to that person's body and ultimately to their organs that can cause a problem. So that makes the match, the find, more difficult, because you're trying to find a donor that not only has one healthy organ but multiple healthy organs that they can use, and again, so they can match that to you. So that can be a little bit more difficult, but that's kind of what they have to go through, and that's something you have to be aware of in the beginning. So not only the failure itself being difficult, the find can be difficult, and then you also have to consider the final care, okay? And what I mean by final, not that this is going to be the end. Hopefully this is the beginning of many years, but you have to sit down. And I would suggest you do this right now today if you got that chance. If you're going into your clinics today, one or the other of those clinics that are dealing with those failures, sit down right now and discuss with them who will have the final say in my care. Say, for example, you're transplanted. Say you were transplanted today. Tomorrow, when you wake up in the hospital, or the next day or the next, or months after, who's going to have the final say in your care? Who's going to determine exactly how your care plan is followed, how you're treated, what priority are given to you in the future, that sort of thing? Because, for example, the heart is a little bit more tricky to deal with in post-transplant care than that of the liver. Not to minimize the liver at all, but the heart is a little bit more tricky to deal with. So a lot of times when you've got a person who gets a double organ transplant and one of those happens to be a heart and the other being a liver or maybe a kidney, a lot of times the heart team's going to kind of take over. They're going to be the primary, the grand finale of the care. They're going to be ones that make the major decisions, because a lot of times you're going to be on some medications, for example, post-transplant, that are very good for the heart. They're necessary for the heart for allowing it to function to its fullest capacity and allowing it to be safe and rejection-free. That can actually do a little bit of damage to the liver and kidneys. For example, I suffer from mild to moderate liver cirrhosis that is based on some of the medications I've been taking for the last 9 years for my heart. And that's just the way it is. Some of these medications do damage to the liver, to the kidney. And so one of those two teams is going to have to kind of take the primary role of your care. They're going to have to be the ones that decide, what medications are used, how are they used, what procedures, what tests, what things are done in your future, as far as out as it may go, hopefully decades. But they're going to have to decide how your care is managed and who's really going to take charge in that, because a lot of times there's a priority that has to stand out in that. Now, that's what you need to be sitting down with. Talk with your teams, whatever those two teams or the combination of them are, and saying, look, who's going to take the primary role in this? I realize, and we realize, that you're all going to be involved, but who's going to take the primary role? For example, I've been put in the hospital post-transplant for some things that are not heart-related, that something like I had the flu, something like one time I had the stomach virus for 14 days. Wasn't a lot of fun. Other issues have arisen where I've been placed over in the hospital. I'm thankful that I always get to go to UAB, my transplant hospital, and I'm thankful that all of those care teams for any organ failure, any organ transplant are available there in the hospital. But I like to see that my heart team is in charge of everything. Not a general medication team, not a general practitioner's team, but my heart team is in charge of everything. As a matter of fact, over at UAB Hospital, if you're a post-heart transplant patient, you're actually placed on an entire wing of the hospital known as HTICU, Heart Transplant Intensive Care. No matter what your problem is, you're placed on HTICU because they see the need for that transplant team managing your care, no matter what the situation is. So everyone that wants to treat you, wants to do a procedure, that wants to put a medication on board or make an adjustment, shoot an IV, whatever you want to call that, they kind of got to pass through that heart transplant team in order to do that. And that's something that's really important post-transplant. It's something that you really need to be talking with your teams, multiple teams right now, and just ask them, who's going to be in charge in the future? I want to know who's going to have the final say in things. So those three considerations: number one, the failure, double trouble; the fine, doubly difficult; the finality, it doesn't need to be double anything. It needs to be a conceded, controlled effort that is headed up or laid out by one of those two teams. Just let them be in charge. That'll help you a lot. Stay stronger, my friends.